All right, everyone. Hi, good evening. I hope the audio and video is okay. You all can hear me, see me very, very clearly. If yes, then please confirm if it is all good to go. Okay. All right. All right. Thank you, everyone. So, guys, today we are starting with our first fast track T&D. Okay, and it will be a very, 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 very quick recap of orthopedics. But even then, my aim would be my aim would be to give you the best of the content that is important for the upcoming examination. And yes, I know that some of you are already very, very clear with the content, with the concept. Yeah. So here we have another group as well. All right. All right. So both the groups are live now. Both the groups are live. So guys, now the aim would be that whatever you read in a typical T&D class, whatever you read there, now the aim would be that to revise and to make some good sketches, good tables, which will help us to revise the content in again very, very quick span of time. Orthopedics, no doubt, is a very, very short subject. Good evening to everyone. Yeah. So I'm going to start up like the paper. As you all can see, the Fast Track T&D paper has been kept a very, very random paper, right? One question from soft tissue, one from clinical test, one from tumors, one from trauma, like that. Okay. So basically the aim was that your mind should not be adamant and fixed on one topic, that sir, this is my topic. Okay, this is, I know that answer has to come from metabolic disorders only, because the topic is all metabolic disorder. All right, so now we have to keep activated your all the neurons, all the axons should be working all the time, and we should be able to catch hold all the questions, no, whatever topic or subject they might be from. All right, so good evening again to everyone. Yeah, so people are still joining. So guys, are we ready to start, everyone? I think we have a very, very good attendance and we should start now. Okay, so that we can very well cover the things on time. So I'm starting with it. See, there are certain sets of things which are very, very important, whether in the NEET exam or in the uh, INI exam, but then both the exam have different strategies. Okay, so but then we have to understand that AIMS has gone a little higher on this time, and INI usually ask you the clinically oriented basic things, right? So let's try to make up the tables, let's try to make up the sketches which will help us to revise the content again more very, very quickly. All right, let's see, let's start with the paper. Please keep on answering. Whenever you answer no, please put the question number also, because there is a lag in when I am speaking and when you are sending me the answers back. So there is always a little lag there. All right, so whenever you send me the answer, just put it as 1B 1C like that. Okay, so what do you think is the correct answer? What do you think is the correct answer? So what is the correct way of doing it? Okay, please, let's not confuse it. I know there are certain app users of a particular platform who are putting the same question again and again. So I would say that let's keep it simple. Okay, there is a whole orthopedics which I can teach you for all the 3 years. So we are not doing PG in orthopedics, we are doing PGME preparation. Okay, so let's discuss. I'll take up your question as well. All right, so correctly identify the given the test which is given below, the very, very first question. So you all know that this way, whenever the person is keeping the wrist like this, what they're doing, they're putting a compression effect, they're putting the compression effect onto the nerve. So that has to be what? Phalanx test, right? That is a phalanx test. Okay, yes, absolutely perfect, absolutely perfect. And the second one you see is what is the test you learn as the Finkelstein test. Okay, now somebody has put a image in the one of the group as HS. I don't know the full name, but HS has put the name. That what is the correct way to do it, sir? Finkelstein is like pulling it, and the other test you have told us like that. So see, understand, the test we are doing, the test we are seeing here, in reality I'm telling you, but there is no need to confuse yourself. In reality, the test you see here is called as ICOF test. ICOF. Okay, this test is in reality called as EICHOFF, ICOF test. But Finkelstein test is just simply pulling the thumb. It is simply pulling the thumb like that. Okay, that is a ICOF test. Okay, but now don't get confused. If nobody is giving you ICOF test in the exam, so just simply go for Finkelstein, right? This is Finkelstein test. Why are we doing it? So two important things I want to tell you here that you all know. Balance test is done for. I'm just revising the things very, very quickly, presuming that you have the idea, and I'm just revamping, refreshing the memories of the subject again. So why this phalanx test is done? You know that phalanx test is done for carpal tunnel syndrome, right? We know that it is done for carpal tunnel syndrome, and this Finkelstein is done for what? It is done for decarmines tenosynovitis, correct? So two clinical tests. Now my idea here is to give you the list of the clinical tests which can be done at multiple locations. Okay, so that is one. Second important thing, when you have talked about the phalanx, we should also know that whenever you are talking about the compressive neuropathy of the median nerve here, then what is the most specific test? Okay, so carpal tunnel, Nelson syndrome. Oh wow, Gotham is like a step ahead of all of us. Okay, so fine. I'll make some tables for the quick recap of the subject. Okay, and how are we planning to do that? So table number one, the first table I'm putting here, the table number one is about the clinical tests. Table number one is all about the clinical test, basically the named, basically I'm talking about the named clinical test. Okay, yeah, Durkan, very very good. So named clinical test and the sites involved, sites or the pathology, basically site or the pathology for what they are done. So I'm quickly revising, very very quickly revising all the orthopedic clinical tests. Okay, starting from the top. So number one is the site is, number one site is carpal tunnel, right? Carpal tunnel. And you all know that in the carpal tunnel, when the nerve is compressed, when in the carpal tunnel the nerve is compressed, the clinical test which we do is called as the different ones, the Durkan test. Number one test is Durkan's test, right? Number one is a Durkan test, and we must not forget that Durkan test is the most specific, or I can say the sensitive test for the carpal tunnel, right? This has been a question of your INA in the previous years, right? Other than the carpal tunnel, what all tests we have, like the pictures which has been given here, it is a phalanx test, what else we can talk about? The other one we can talk about is the Tinel sign. What we can talk about is the Tinel sign, and the fourth one is what you learn as the tourniquet test. Okay, the tourniquet test. Okay, so carpal tunnel syndrome, so Durkan test, phalanx test, Tinel sign or tourniquet test. Okay, these are four for the carpal tunnel area, right? The carpal tunnel. Second site or the second pathology basically is at the base of the thumb. You know, the base of the thumb. What do you do at the base of the thumb? The problem is what? The problem is decarmines tenosynovitis. The problem is decarmines tenosynovitis. Okay, decarmines tenosynovitis. Sorry, decarmines tenosynovitis. Inflammation of what? The abductor pollicis longus and extensor pollicis brevis. Abductor pollicis longus and extensor pollicis brevis. What is a clinical test you do? Like I told you, this concept here, ICOF, or simply whatever is given to you in the exam, Finkelstein. I know there are so many students of other platforms which are going too extensive. Don't do that, guys, please. Okay, so ICOF and Finkelstein. Now when you're talking about inflammation of APL again gives you so many MCQs. For example, APL, you should know that it is an inflammation of APL is called as what? Decarmines. Inflammation of APL is called as decarmines. Second, whenever there is a fracture which it displaces APL, you know, remember the fracture it displaces, APL displaces which fracture? Do you remember that? APL displaces which fracture? You remember the attachment on the base of your thumb. What is the name of that fracture? The name of that fracture is Bennett, right? Name of the fracture is Bennett. Okay, so number third, when it is the radial nerve, you know, supply here, APL supply is what? Radial nerve. That is usually a exception. In your muscles being supplied by the median nerve. You know that all the thenar eminence is a supply of the median nerve. All the supply is of the median nerve, and on the back of the thumb here is the APL, which is getting a supply now from radial nerve because it lies in territory of radial. So APL has got three questions. Inflammation of APL, decarmines test we are talking about, Finkelstein. Okay, I hope it is fine. Number two, you go a little, you know, in the thumb area, decarmines is one. Number three test which can be done at the wrist itself. Number third test, name test, which can be done at the wrist itself. It is called as the Cozen test, or basically for the tennis elbow. It is for the tennis elbow. You all know that tennis elbow is what? Lateral epicondylitis. The lateral epicondylitis. Okay, so lateral epicondylitis, what is the clinical test done? The name of the clinical test is called as the Cozen's test. Name of the clinical test is called as Cozen test. Number three, tennis elbow, right? Tennis elbow here, Cozen test. Ask the patient to make a fist and go for extension of the wrist, right? That is number three. Number four is a very simple test which can be done in the hand area, the finger area. What are those? I'll name the test and the nerve involved. So in the hand, what all we can talk about is What all we can talk about is a nervous injury and all. I'll take a little, separately, so that we can make a good table. But then when you talk about the fracture, which kind of fractures we are talking about? Fracture, for example, the site and the clinical test only I am putting. So whenever there is a fracture of the supracondylar humerus, you know that the involvement is of the anterior introitious nerve. You remember that? Anterior introitious nerve. And anterior introitious nerve is tested by what sign? The OK sign. Why OK sign? Because we are talking about the flexor pollicis longus and the flexor digitorum profundus, right? These two, the OK sign. If it is not happening, the OK sign in the fingers, again it is related to fracture supracondylar humerus, right? The name sign. So patient will be having or presenting you the picture with like this, right? No flexion, it is only extension, right? Like this. So extended finger and the extended thumb, the supracondylar. Then we go a little up, the clinical test. After this, see, we are trying to go up in a sequence so that we can recall as many as things we can, right? Number 1. So number 5 is supracondylar humerus. Then we talk about the injury, to the fracture lateral condyle. So please remember, in the fracture lateral condyle of humerus, there will be no named clinical test, but we know that the nerve involved is a late involvement of the ulnar nerve. It is a late involvement of the ulnar nerve, leading to what kind of problem? There will be ulnar claw, or there will be ulnar nerve tingling. So I am putting this here with the supracondylar so that things remains in mind. Supracondylar AIN, lateral condyle, the tardial ulnar nerve palsy. Then we go a little up. In the entity called as the thoracic nerve part, I'll make separate. Okay, thoracic outlet syndrome. I'm just putting the named clinical test here. Thoracic outlet syndrome. You know that thoracic outlet syndrome can be of two types, right? It can be the vasculogenic, it can be neurogenic. Whenever you are talking about the vasculogenic one, you know very well that the vasculogenic one, basically it compresses what structure? We know that it compresses the subclavian vessels. And for the compression of subclavian vessel, what are the different clinical tests we have? For the subclavian vessels? So for subclavian vessels, the test number 1, you can learn it like what? RA raw. Very good. RAW is raw. Perfect. Very good. So it is called as the Roos test. It is called as the Addison. A is called the Addison test. And W is called the Wright test. Okay. Right. So Roos, Addison and Wright test. So name test Roos. This is Roos. Addison is turning the neck to the side and extending it. Pulse become feeble, and Wright is elevating the hand. So thoracic outlet syndrome name test is the Roos, Addison or Wright test. Okay. So in the upper limb, these are few of the name tests. Now, along with the upper part of the thoracic outlet, we know that whenever there is an injury to which muscle? Whenever there is an injury to subscapularis. Whenever there is an injury to what? Subscapularis. What is the name? What is the test we do? If you remember, we have always talked in the soft tissue disorder. It is called as the lift off test. It is called as what? The lift off test. Keeping the hand on the lower back and trying to elevate it. That is lift off test, right? So for supra or subscapularis, it is a lift off test, right? Number 8, we go in the spinal area. The name test I'm saying, then the spinal area, right? In the spinal area, you start from the conditions called as the ankylosing spondylitis, right? The conditions of ankylosing spondylitis. Yes, ankylosing spondylitis. Now you know that ankylosing spondylitis means what? Ankylosing. Ankylosis is what? Pathological fusion. So ankylosis of spondy. Spondy is what? Vertebra. Itis is what? Inflammation. So ankylosing of the spondy because of itis. Inflammation of spine, the vertebra because of inflammation. What are the clinical tests we do? So in ankylosing spondylitis, at the sacroiliac joint, because we know sacroiliac is the first joint to be involved. So what is the test we do at sacroiliac joint? The test to be done for sacroiliac joint, it is called as Gansilin or the pump handle test, right? Gansilin or the pump handle test, if you remember. And then when it involves a lumbar spine, then what you do in the vertebral area? What you do? It is not Schauber, Gautam. It is not Schauber. It is modified Schauber. Yes, Rushabh has said it very, very correctly. Okay, in the lumbar spine, what we do is modified Schauber's test. Okay, it is modified Schauber's test in the lower area, basically the sacroiliac joint or the lumbar spine. Okay, that is the Gansilin, pump handle and the modified Schauber's. Okay, in ankylosing spondylitis. Then when you talk about the entity of congenital dislocation of the hip, when you talk about the this entity, congenital dislocation of the hip, then what is a test? What are the tests which has to be done? So there are three tests, if you remember. The first test was what? Ellis test, Ellis sign, Ellis test, or the Galeazzi, basically, not Ganselin, it is a Galeazzi. So it is Galeazzi sign or the Galeazzi test. So Ellis sign, Galeazzi test, they are the same thing. Ellis test, Galeazzi sign, they are the same thing. Okay, so these are the same thing, right? So yeah, all right. So these are what? CDH, the Alice test, or the Galeazzi sign, or the Galeazzi test, right? What is the other test you do? You know that the other name of the test here is Barlow's test, and the other name is what? It is a Ortolani test, right? It is a Ortolani test. So we do Alice, Barlow, Ortolani. Perfect, perfect. Biord is very, very correct and very, very quick as well. All right. Now, yes, Alice, Barlow, Ortolani. Perfect, Anushka. Very good. And number 10, at the same site around the hip area, if you remember, in the TB hip, when somebody has suffered from TB hip, there is one very, very important test, called as what? The Thomas test. Remember the TB hip, remember the Thomas test. Why we do it? It is done for the fixed flexion deformity of the hip. It is done for fixed flexion deformity of hip. It is done for fixed flexion deformity of the hip, the TB hip, right? The Thomas test and the fixed flexion. It is a repeated question in the recent years. All right, we go a little down. The CDH done, hip done. We go to the knee area, and you remember in the knee area, what are the test, name test? When you talk about the cruciate ligaments, what are the tests we know? We know that they are anterior and posterior drawer. They are anterior and the posterior drawer, and the anterior one is also checked by Lashman. What is the basic difference? You know that Lashman will be checked by minimal flexion of the knee, 20 degrees, and drawer will be checked by 90-degree flexion of the knee. Then in the knee, we have the test for the menisci. Then in the knee, we have the test for menisci. And in the menisci, what are the tests? You know very well. What are the tests? The McMurray's. The test is McMurray's, right? McMurray's. And what is the number 2? The test is McMurray's. And number 2 is Epley's grinding. Remember that? The Epley's grinding test. The Epley's grinding test. So these are the all tests that we usually write down in our class, and we understand how to do them. Just we are concising them. Okay, in the knee. And then in the ankle area, for the integrity of the tendon Achilles, if you remember, for the integrity of the tendon Achilles, what is a clinical test we always talk about? Yes, absolutely, Anushka is correct. So it is the Thompson test. Yes, it is 20 degree. You marked it very McMurray, Epley, grinding. Yeah, everybody is going very, very correctly. Okay, so this is just a list of some concise tests which are expected, which are usually asked in our routine examinations, right? So I hope it is fine. So would you like to make some more tables like that only? I hope that is a way to conduct a fast track T&D. That will be little useful for all of you. If you want, we can go like that only. Okay, if you want, we can go like that only, the Thompson. Okay, so we have incorporated almost every test. If you think I have missed out anything, please let me know. I'll be more than happy to incorporate it. Okay, so that is one. Okay, that is how we are going to revise our whole paper. Okay, whole orthopedics. Perfect. That is fine. Amod, Mumal. Okay, so our question number 1, I hope the question number 1 is fine. Now purposefully I have not taken this test number 3 here. Okay, knee squat test. Is Shruti not a very the question which is for their exam. Obviously there is a lot of theory which we are skipping here. Okay, so Trendelenburg is there, Rishabh. I know that has not been taken for a purpose because we have question number 3 is Trendelenburg. So there is little more thing I want to discuss. If you wish to add it here, there is no problem. I can add in the list only. So I'll just finish up with the list as Rishabh has pointed out. So I'll just end up this as well. The Trendelenburg, basically, it is a repeated question of your last few sessions of the exam. Okay, so Trendelenburg test is basically, you all know that why we get it done. Trendelenburg test, it is for the integrity of the abductor mechanism of the hip, which is being given by the gluteus medius and the minimus, and the nerve which supplies it is the superior gluteal nerve, isn't it? The superior gluteal nerve. So Thomas test, basically the Thompson for the tendon Achilles we have written over here, and the Trendelenburg is for the gluteus medius and the minimus. It is for the gluteus medius and the minimus, right? So this is what you have to do, the Trendelenburg test, medius and minimus. Okay, that is fine. The superior gluteal nerve, absolutely correct. Now the point which I wanted to actually highlight here, please remember that Trendelenburg test is exactly, you are absolutely right, it is done for the gluteus medius and minimus. But then in the very recently conducted IN exam, we had a question about the common peroneal nerve getting injured at the proximal fibula, and they asked you that how the patient is going to have the walk, what kind of gait. Please remember, whenever we are talking about, let me just complete that table as well. I'm going to talk about three important things. Let's finish here only. Whenever somebody has, let's suppose Trendelenburg, we said, is for what? It is for integrity of these two muscles, the gluteus medius and minimus, and the nerve supplying them. Okay, but then in Trendelenburg we should also understand that if somebody has a pathology called as the congenital dislocation of the hip, if somebody has a pathology called as congenital dislocation of the hip, then what happens in that case? What happens in that case? Okay, what happens in that case? Unilateral neglected, I'm talking about the neglected cases, obviously the children who are neglected, not examined at the birth. So neglected CDH, how they walk with the unilateral Trendelenburg, that means the dislocation basically. So they will have the Trendelenburg gait. Please remember, it will be having a Trendelenburg gait, right? That is one. And if somebody has a bilateral neglected CDH, how is supposed to walk? He walks with a Wedeling gait. So please remember, the hip problem, the muscle problem here, or the nerve problem here, is going to lead to unilateral and bilateral. Abby is correct, Roshav is correct, Ankita, Shruti, everyone is right. Anushka, you are right, absolutely correct. Okay, now this is the nerve injury and the gait. We have talked about one. Second one is about the common peroneal nerve. You're absolutely correct. It is not only about common peroneal, actually it is about the sciatic nerve as well. You know very well that the common peroneal nerve is involved where? It is involved in the proximal fibula, and to be very, very precise and specific, in proximal fibula, where? In the neck area, right? On the other hand, the sciatic nerve, you already know that it is most commonly involved whenever the patient is suffering from either the posterior dislocation of the hip, or somebody has been done a this hip replacement basically from the posterior aspect of the hip. So sciatic or CPN, they both will lead to the similar kind of picture. And that would be the foot drop. Yes, absolutely correct. And whenever there is a foot drop, how the patient walks? He has to walk with a high stepping gait. The high stepping gait. Okay, it will be high stepping gait only, right? It is a high stepping gait only. Absolutely correct. Nikhil, Shruti, everyone is right. Aisha, absolutely correct, guys. Okay, fine. Okay, so this is like how the presentation of patient is, or the gait will be. These are 2-3 important gaits which are commonly repeated in your routine theory, so you should know about them, because this has been the question one time, so others can do the question anytime, right? So this is about the table number 1 that we have made for our question number 1, and including the question number 3. Let's understand. Okay, I hope it is fine with everyone. No problem, we can go at the same pace, because obviously we have the time constraint and we are revising it actually to a very in a quick manner, effective manner. We have to do it. So all of these can be used in the procedure of skeletal traction. You know very well skeletal traction. Okay, so Steinman pin, Denham's pin, Bowler stirrup, SS wire. What do you think it is? So correct answer is yes, absolutely correct. It is SS wire, the stainless steel wire. It has to be the stainless steel wire. Absolutely correct. Now let me show you very quickly how these actually look like. So when you look at certain instrument implant, let's see them as well. What is the basic difference if they ever ask you? See, skeletal traction means now you're putting a traction through the bone. So how do we put the traction through the bone? So we have the Steinman pin. Okay, not this file, the other one I need to open. So splints and traction, guys, these are 2 files which are available on my Telegram group in the media section. You can just go there, download it, and you can download these 2 files as well. These are available in your eGurukul app as well, so you can open up that as well. Okay, now see Steinman and the Denham's pin. Now see this one, Steinman, how we pass this Steinman pin or the Denham's into the bone. Let's suppose I'm doing the skeletal traction for the tibia. So what we do is we just pass this pin, the Steinman pin. Okay, it is like this. You can see one of the end is pointed, and to these two sides, what we do, we apply this is a pin inside the bone. And what you have done, you have put a stirrup along with it, and that is what you call as a bowler stirrup. Now what is the aim here? To this I'll be applying some weight. So whenever there is a traction applied like that, then we have a pull to be done. So that is the skeletal traction. So I can use very well the Steinman pin, the Denham's pin, which will have the threads in the length, so that it is used in osteoporotic bone. So if the bone is weak, it can easily hold the bone and it doesn't easily slip down, right? That is Denham. So Steinman, Denham, and these two will be fixed by what then? the bowler stirrup, so that you can tie some weight and the traction can be achieved, right? Sometime for the smaller bones, what we can do is, in the smaller bone, sometime we can apply simple K wires as well, like this phalangeal area. I'll apply the K wire and I'll try to pull it, right? That is again a skeletal traction. So smaller bones we can use K wires, bigger bones the stem pin, denim pin, depending on quality of the bone, right? So bowler stirrup. So what can't we use is a simple stainless steel wire. That's a very, very logical point. How can we use the stainless steel wire? What is the stainless steel wire? This one, you know that very well, right? So stainless steel wire cannot be used for this. NEET is not a test for the, like, you know, a very, very important one. There is a long list, then there is a empty can test also. Okay, so I'm not going to do that much of the whole orthopedic part. I'm taking whatever is the most important. And again, guys, you know very well, you are smart enough to understand that nobody can say that whatever we are doing NEET will never be asked in the exam. It's not like that. NEET is a question which may be asked, but then, you know, anything which is extra, additional, it is not like that everything has to be there. Okay, so these are the basic points we are covering up. Okay, so I hope it is fine with everyone. The question number 2, you answered it very, very correctly. Option is D. Third one, patient when made to stand on right side of the limb and asked to elevate left side of the limb could not do so, and left pelvis dropped down. Which nerve is faulty here? If somebody can answer me, please. Which nerve is faulty here? The right side or the left side? Which one is faulty nerve? If you can answer that. Sciatic nerve injuries due to posterior dislocation of the hip. Absolutely. Yes, you are right. Absolutely, you are correct. Okay. What is the answer for this question? Question number 3. Nobody answered yet. Yeah, nobody answered it yet. Third A. Okay, the right superior gluteal nerve. Absolutely correct. It is the right superior gluteal nerve, right? The concept should be very, very clear. This has been a very, 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 very important. Yeah, Vishal is right. Anushka is right. Zubair is right. Meher is right. Yeah, Ananya, Mavya, A. Yeah, absolutely. Shruti, everyone is right. Okay. So we are checking for the side on which the patient is standing. So these muscles which are over here, they must contract. When they contract, the other pelvis can be kept at the same level. Absolutely correct. Perfect. Perfect. When performing a replant of an amputated finger, which of the following is the correct order of surgery? Which of the following is correct order of surgery? How do you remember it? If you remember this, see, this has been a little controversial question between the orthopedic and surgical classes, but yes, I have the logic, we have the reference, and we both, the surgeon and the orthopedician, we both believe in that, right? What is that? What is the mnemonic? Be a fan of whom? Be a fan. This A has to be small. Be a fan of what? The VS. We can have the VS as Virendra Sehwag, no doubt in that. Okay, so be a fan of VS. Aisha is absolutely correct. Be a fan of VS. Okay, so what does it tell you about this one? What does it tell you about this one? Which one is correct here? Fourth, D. Yes, absolutely correct. Okay, so third A, yes, Kamran is right. Fourth is D. Okay, fourth is D. Absolutely correct. Absolutely correct. Okay. Right, this is absolutely correct. Now number 5, all are correct about the lesion shown in the picture here except, okay, this is a picture. Tell me the diagnosis for this one first. What is the diagnosis? What is the diagnosis? How do you make a diagnosis of this? Have you been able to make the diagnosis for this? So diagnosis for this, how do we make the epiphyseal? I have always told you how to make a diagnosis. Always the first point to be seen is the location. Epiphyseal, metaphyseal and diaphyseal. Which one is this? ABC. Yes, absolutely correct. It has to be ABC. Absolutely correct. It has to be ABC. Right? Aneurysmal bone cyst. Absolutely correct. Now, which of the given point about this is wrong? Now, see, ABC is some pathology which is seen in the age of pediatrics. Right? Where the growth plate is actually open. Right? So it is not seen mostly in adults. No, it is most commonly seen in a child. Most commonly seen at metaphyseal location. Yes. And what is the typical appearance we call it about this? This is what you call as the soap bubble. So soap bubble appearance, the soap bubble appearance at metaphyseal area. The soap bubble at metaphyseal area is what? ABC. Giant cells are usually present on histology. Is that so? Yes. Why not? Remember the mnemonic given in your workbooks as well. What is that? C, C, F and Bantu. So let's not get into that much of fuss, so that we don't know or we know. Yes, it is having giant cells. On aspiration the blood is seen. That is why it is aneurysmal. Right? Blood is there, no, for the reason that it is aneurysmal. Yeah, absolutely. So I hope that approach to the bone tumor is very, very clear to everyone. So I have put here 2 things. Now I'm just putting the third thing here about the bone tumors. I'm just putting the point number 3 here about the bone tumors. the table number or the point number, basically 2 you can call it, 3 you can call it, whatever you want. The number 3 I'm putting it is about basically the tumors. Okay, so always remember, always remember, I always tell you all to just concise your content. And how to do that in the tumors, you just have to remember the sketch which I always show you in my class as well. So what about this one, this image? I hope that everybody is having this image and you're using it to revise all your bone tumors in a very short span of time. So just one image is showing you, that at what site what lesion can be common with what all features, right? What is a basic approach? We all have to remember that. Yeah, so what will be the basic approach? Basic approach would be, for any of the bone tumor, would be that you first have to see what in any of the lesion, you will have to see the location. Just see the location. Location would be epiphyseal, either it is metaphyseal or it is diphyseal. Epiphyseal, metaphyseal, diphyseal. Okay, annotated PDF as well? No, that will not be possible. You all have to make the notes, you have to write down as I'm writing. Okay, so second one after the location, is try to figure out the nature, whether it is benign or it is malignant. And the number third is to see if there is any special feature or no. All right, any special feature or no. So location, nature and special feature, right? So here in this case, what you have seen is the location. Here in this case, those who are very new to my class, I'll just revise my basic things as well. So here, the location is metaphyseal. Second, what kind of nature? See, cortices are still maintained, they are getting expansile, so seems like a benign one, no periostal responses. Third, special feature, the septations here, right? Kind of soap bubble. So kind of soap bubble at the metaphyseal area seen, where it is what you call as the, yeah, it is there. Can you please share the photo of tumor chart? See, while taking a class, it will be difficult, but if you want, you can go to my Telegram group and download from media, or after the class is done, do tag me. I'll share anything, whatever you want, right? So it is there already. All right, so in the class it is difficult because that has to be a mobile device, and right now I have my laptop with me. Okay, so this is the way to approach, right? So all the time, please try to have the basic fundas with you. Okay, what I'm going to do in the tumors, to have a quick recap of the tumors, what I'm going to do in the power course as well, we have done that in the all the time in the classes also. What we do that is a drawing of a normal picture to revise the tumors. Okay, so let's see some more tumors, and then if required we can draw that table, the location, the nature and the special feature, or I can just cover it up here itself. Okay, epiphyseal lesion, the picture that I've just shown you, you know very well that epiphyseal lesion, let me just put it like this. Epiphyseal lesion, how do I differentiate? First thing to be seen in the tumor is epiphysis, metaphysis or diphysis. Now we know that epiphyseal lesion, yeah, somebody has shared it from the S. Thank you guys for being so supportive. Somebody has shared the picture already, very good. So epiphyseal lesions basically are two. What are those? One is the GCT, which is also called as what? Osteoclastoma. GCT, or what you also call as osteoclastoma. And second one is what you call as the chondroblastoma. Now what is the simple and the basic difference in between them? What is the simplest and the basic difference in between them? The clast and the blast. So name itself is telling you the difference, right? GCT and chondroblastoma. What is the nature they both have? GCT or chondroblastoma, they both have the benign aggressive nature. Meaning by what? Wherever they are present locally on the bone, they will destroy the bone like a malignancy. They will destroy the bone like anything, right? That is benign aggressive nature. Now somebody said age, like Shruti said age. Now see, age, which will be more common in a child? Which of these lesions will be more common in a child? The osteoclastoma or the chondroblastoma? What do you suggest? The chondro. What does that mean? Chondro, it is a child. So epiphyseal lesion in an adult between like kind of skeletal maturity, after that time, is GCT. Okay, and this one, any epiphyseal lesion in a child, it is chondroblastoma, right? It is chondroblastoma. Yeah, chondro is in child, benign aggressive nature. Absolutely correct, right? That is a basic way. So let's see some images also to just clear the facts. If there is a exam question, how will that be coming? Let's see. Let's finish it up here as well. So when you look at this, these two images I'm going to show you. Yeah, look at these two images. If you just appreciate them, what do you see? The mature skeleton, immature skeleton. Can you all appreciate that? Immature skeleton, and the growth plate is also damaged. So This side, if you look at the radius here, the lateral aspect of the radius is maintained, but medial aspect of the radius is already broken. So when the margin is broken, it is a benign aggression. It is a benign aggression, and here it is all again aggressive. That is what you call benign aggression, right? So they're damaging the growth plate as well. All right. Second area is always the metaphyseal. What are the lesions which you can see at metaphyseal area? Benign first. The benign metaphyseal area, we can have all the three categories actually. We can have the benign lesion, we can have the malignant lesion, we can have the benign aggressive lesion. All the three are quite possible. Okay. The number one, the benign lesion. They are, number one is osteochondroma. Right? Number one is osteochondroma, which you know is a polyp-like growth. Second one, these can be unicameral bone cyst. Or the simple bone cyst, right? Simple bone cyst. And we can have a defect of the bony formation, which is also called as NOF, right? NOF. So how do we differentiate these simple, things? Osteochondroma has been a recent year question, so it's a high possibility of coming in the exam. You know that osteochondroma is not a real tumor, right? It's not a real tumor. It is something which grows with the skeleton. As the patient is growing, it keeps on growing, right? It grows with skeleton. Okay, it grows with skeleton. So that is why it is not considered a real tumor, osteochondroma. And this osteochondroma is of two types. You know that very well: sessile type and the pedunculated type. And in sessile and pedunculated, the most important catch point always is what? The stalk here. The stalk. When you talk of the stalk of the lesion, whenever you talk about the stalk of the lesion, the stalk is always deviated away from the joint line or the growth plate. The stalk is away, always it grows away from joint line, right? That is about the stalk. It always goes away from the joint line. Number three is always about grows with the skeleton, sessile and pedunculated, right? Number three, that osteochondromas, whenever they are occurring onto the surface of bone, they always have a cartilage cap, which you should never forget, that cartilage cap always goes less than 2 centimeter. It doesn't go beyond that, right? So it is not a real tumor. It keeps on growing with the skeleton, and it is of two types, the sessile and the pedunculated variant, right? Now cartilage cap is always less than 2 centimeter. So not a real tumor. Okay. UBC, what is a classical point we know about UBC? The classical point we know about UBC is what? The fallen fragment sign. Remember, the piece of bone into the cavity, the fallen, yeah, absolutely. Blood in DBMCI. Oh my god. Blood in ABC you wanted to say, I think, Anushka. Okay. Anushka is saying blood in DBMCI or ABC. So fallen fragment sign. Okay. The fallen fragment sign. Yes, absolutely. Okay. Absolutely. The fallen fragment sign. Okay. Simple bone cyst or ABC is basically the same thing, right? When you talk about the UBC or the SBC, it is the same thing. Then we have another cystic lesion which I'm talking about here is the ABC. ABC means, obviously, yes, you're right. Absolutely, you're right. It is a blood. Okay. It is a blood. So yeah. So it is the blood. When you aspirate, it is blood. And yes, we talked about it already, that there will be septations. Which we are calling as what? Simply, we called it what? The similar appearance to the giant cell tumor, right? That is a soap bubble. So septations, soap bubble at metaphyseal area and soap bubble at epiphyseal area. Please remember. Okay, soap bubble, yes. And NOF is the most commonest benign bone lesion. It is present in like kind of 30% of patient. Now in the metaphyseal area, we do have a benign aggressive lesion as well, which you learn as osteoblastoma. And how is it basically, different from the other lesions? We'll just talk about it. And the third one is aggressive lesion. Aggressive lesion which you learn here is osteosarcoma, where you see two classical pictures. One is Codman's, and other one is what you call the sunburst or the sunray. So sunburst or sunray. All right. So this is how you see all of them. I'll just write down all and I'll show you all the pictures. Okay. And then we have the third category that is located at diaphyseal area. So in diaphyseal area, we also know that we have got both the categories, benign category, and we have got benign, or simply I can write aggressive category, right? Aggressive category. Now in the benign, we have got two malignancies, basically two tumors. One is what you call as osteoid osteoma. As the name is suggesting, it is coming from osteoid itself. So what did we see in osteoid? we see sclerosis around the lesion, sclerosis, whiteness around the lesion, and the size of the lesion is always less than how much? 1.5. And when it goes more than 1.5, if the size you see in ever it is more than 1.5, it favors what? Osteoblastoma, right? It favors osteoblastoma. And the other tumor, other lesion we see here is fibrous dysplasia, and in the fibrous dysplasia, typical picture seen is what? This was a recent year INI question as well, the May session. It is Shepherd-Crook deformity. It is Shepherd-Crook deformity, right? Now the aggressive lesions that you see here, one is adamentinoma, and what is that adamentinoma? It is showing you what? Honeycomb. It is showing you what? Honeycomb. And the other one, the adamentinoma, and other one you all know is Ewing's. And what do we see typically in Ewing's? It is a onion peel now, right? It is a onion peel appearance now, right? So that will be onion peel appearance. So onion peel appearance is seen where? In Ewing sarcoma, and adamentinoma is showing you what? Honeycomb appearance. Okay, so that is how you differentiate between the different malignancies, right? The location, the nature, two things. Now the third most important thing is to understand very simple fact about the bone tumors. What is that? That whenever you are talking about any of the benign lesion, right? Whenever you are talking about any of the benign lesion, the simple treatment is you have to just remove it and fill whatever area you can. Okay, so all the time remove it and fill it. So removal is what you call as the curettage, right? It is called as the curettage. And after that, what you can do? Put some bone graft, put some bone cement, whatever is best for that area. But then sometime the lesion has to be a liquid one. For example, like this, the UBC, SBC, or this ABC. In that case, always remember guys, in that case what we do? We always aspirate. We don't want to open it. So we go for aspiration. As well as with aspiration, what you do? With aspiration, we go for sclerosants. Okay, we go for sclerosants, the sclerosing material, which will help in dissolution of the lesion, right? The size of the lesion. So liquid lesions, aspirate; solid, semi-solid, clean it and fill it, and whatever is malignant, just amputate it. But please remember, whenever you are going for amputation, we try to reduce the size of the lesion, and that is done by what? The neoadjuvant chemotherapy. Remember, neoadjuvant chemotherapy, right? What is the role? To reduce the size of the lesion. And sometime when the lesion is little different, little typical, which one? Osteoid, osteomas, what you do? You can give NSAIDs. You can go for radiofrequency ablations. Okay, so this is a broad picture of all the tumors, their location, their nature, their special feature, and the planning of their treatment. Right? This is fine with everyone? If you all are with me, can we have some thumbs up? I should know that how much is the real attendance as of now. If you can please let me know how many are live with me in various channels. Okay, so let me just see if how many are live with me. All right, so this is the second table we have made, right? This is fine. Is it going fine with everyone? Right. Okay. All right. Right. So is it going okay? Great. We shall be making some more tables very soon. Okay, we shall be making some more tables very soon. So let's continue. All right. So many students with me on multiple groups on YouTube. Oh, good to see such a good strength. Wonderful. Perfect. Okay. So now see, radiotherapy somebody mentioned. Yeah, Rishika, I agree. See, chemotherapy, neoadjuvant chemotherapy or radio, whatever you need to reduce the size of the lesion has to be given first, and then we go for the desired surgery, right? That is your next lesion we had. Okay, so let's talk about next question. So question number 5 is fine with everyone? Yeah, perfect. Anushka is right, absolutely. Jamshir is right. Remove and fill. For aggressive also, for aggressive I told you, Jamshir, for aggressive always the answer is amputation, but before doing amputation we have to reduce the size of the lesion. All right, now number 6, a 18-year-old child sustained an injury to the elbow region around 6 months back, right? It was managed conservatively. 6 ka D. Okay, so 6D, it is already highlighted. No, don't be that smart. Okay, whatever you have marked, please tell me that only. Don't try to cheat, right? Don't try to cheat. So 18-year-old child sustained an injury to the elbow like kind of 6 months back. It was managed conservatively by plaster application, and gradually they developed deformity around elbow and now is getting gradual flexion of the medial two fingers. What is the most likely injured site in this patient? Why do you say it is a lateral condyle? Why do you say it is lateral condyle? Please tell me the reason. Please tell me the reason why it is tardy. Yeah, Shruti has answered it very accurately. The tardy ulnar of PLC. Okay, so now we are going to make up a table in which we will discuss that what all sites in which all fractures, basically, what all nerves can be involved. Some of them I've included here in the clinical test, but now I'm just going to talk about the fractures, simply the fractures and the nerves involved. And now if the fracture is involving the particular nerve, then what is the usual presentation of the patient? That table will make. Okay, let's see further question as well. Lateral condyle is absolutely correct. Hand of benediction. Oh, come on, Kamran, what are you saying? Hand of benediction. It is not hand of benediction. Kamran is a little wrong here. Okay, yeah, you marked wrong, Anushka marked wrong. Okay, great. So now you got the concept here. Anushka got the concept here. After a long time, 6 months. Yes, absolutely correct. Perfect. So now it is a child who has been managed 6 months back, right? Trauma was old, and now gradually he developed some deformity around the elbow and is now getting gradual flexion of medial two finger. Nowhere it is written where is the injury. Why after like kind of 6 months he is getting some clawing of these two fingers? 6 months. That means this two finger involvement means ulnar nerve is gone. But why after a long time? So long time means is called as what? The tardy, late involvement of ulnar. It is related to what? The cubitus valgus deformity, right? The cubitus valgus deformity. It is related to valgus deformity, and valgus is seen in which fractures? Whenever the lateral condyle has gone into non-union. I hope everybody recall that. Everybody recalls that. Yeah, perfect. Biot has answered it very fracture of necessity. Absolutely, Rishabh. Biot, very good, wonderful. Seventh one. 40-year-old man has sustained injury and got severely comminuted fracture as shown in the X-ray, and is now unable to flex the elbow, and there is loss of sensation on the upper lateral aspect of forearm as well. What is the most likely nerve involved? Please tell me this one. Please tell me this one. What is the answer here? Somebody has got a fracture, comminuted fracture of the shaft of the humerus, right? Somebody's got a fracture of the shaft of the humerus, and what will be the most likely nerve involved if the patient is unable to flex the elbow and there is loss of sensation on the upper lateral aspect of forearm? Rushabh is right. Rushabh is right, absolutely. Safana is right, Mumal is right. So everybody is right here. It is a musculocutaneous nerve. Radial, come on Vishal. What are you saying? Radial. Vishal is trapped. Vishal is trapped with the theory. Okay, Vishal, now see, look at the presentation. Okay, this is something very important. Okay, this is very important. We have to understand. Okay, Anushka again is with this nerve. Anushka is also saying radial nerve. Why is it so? Understand. See, what our mind is fixed up to is to see this picture only, to see this X-ray only. But what we have to look upon is the clinical presentation of the patient. How is the patient coming to you? Patient is not able to do what? Unable to flex the elbow. Second, there is loss of sensation on the upper lateral aspect of forearm. Why somebody is not able to flex his elbow? Because his biceps is not working. Obviously, that is the flexor we have, and biceps will be supplied by what? Musculocutaneous nerve. Musculocutaneous has a sensory branch, lateral cutaneous nerve of forearm, and that is why there is a sensory loss. Okay, so tardial nerve, PLC, lateral condyle. Okay, fine. Okay, this one is clear. This one is clear. So do not, once you put an answer into the group, don't delete it. That's okay. Having wrong answers here is very much acceptable. But our job, my responsibility is when you go to the exam, your every section of orthopedics should be absolutely fantastic, right? So wrong here is okay. It's welcome. But you should go home with the right answer. Okay, Vishal, I hope it is clear. Yeah, Vishal has responded well. Okay, perfect. Anushka, I got your point. It was a little lag in the message you typed and sent. Okay, so now can we see the next one as well? Okay, let's see. Yeah, let's see the next one as well, and after that we'll make the table. So we will make the table after this. Okay, let's make the table after this. 7-year-old child presented in OPD with the presentation as shown in the picture. Histories of 7 days old trauma. Managed conservatively. Which of the given statement is wrong about this shown condition? What is the diagnosis? Can somebody please tell me the diagnosis? Can somebody please tell me the diagnosis here? What is the diagnosis of this fellow? What is the diagnosis of this fellow? Can somebody tell me the diagnosis? It is 8th D. Kamran has said 8th D. Okay, but Kamran, what is the diagnosis? Please tell me that as well. Okay, so it is the which one? Supracondylar. Very good, perfect. I appreciate you were able to easily recognize it. It is a fracture supracondylar humerus. Absolutely right, absolutely correct. Okay, fine. So You Kohli's, come on, Umesh, you are on the next level. Kohli is in the elbow area. Okay, Kohli is in elbow. Don't do that, man. Okay, supracondylar, everyone is right, everyone is right. Okay, everyone is right. Extension type, man, is too good to answer it. Very, very good, very, very good. So you are most commonest is extension type, and this one is what type? See, the distal fragment is going on the back side. The distal fragment is going on the back side, so it is an extension kind of supracondylar. Okay, so we know, yes, most common is extension only. 3-point relationship is usually maintained. This has been the recent year question as well, the recent session actually, November session. So most commonest, brachial artery is involved. Very good, Kamran is right. It is not the radial, it is the brachial. It is the brachial artery which is involved. Perfect, absolutely correct, absolutely correct. Okay, so brachial artery is involved. Okay sign can be involved. I told you already, no guys, I told you already. Okay sign can be assessed to know most commonest nerve involved. Okay sign can be involved. The AMRU, absolutely right, Rishabh, absolutely right. So we talked about this supracondylar leading to AN involvement, right? So fracture, the correct answer here is option D, absolutely correct, right? So now I'm going to make a table. I'm going to make a table to know that at what all sides, what all nerves can be involved. At what all sides, what all nerves can be involved. Let's make a table number 4, the entity number 4. Okay, let's make the table number 4, the sides and the nerve involved. Okay, at what all sides, what all nerve can be involved. So table number 4, table number 4. So it is not about the trauma anymore. It will be like any condition which leads to involvement of any nerve, right? So we can say the nerves involvement or the entrapment neuropathies, right? Nerve involvement or the entrapment neuropathies. That's how we have to learn it, right? Table number 4. Okay. So site and the nerves. Okay, site and the most commonest nerve involved. Okay, the site, the fracture site and the nerve involved. Okay, I'm writing it like as a fracture site, entrapment site, whatever you want to call. AMRU, sir, this one, is this order is correct? Yes, absolutely correct. Yes, it is absolutely correct. So fracture site, we start from the hand area itself. So fracture of scaphoid, fracture of the scaphoid, the dislocation of the lunate, fracture of the scaphoid, the dislocation of the lunate, and the third, the Kohli's fracture and the Kohli's fracture, they all lead to involvement of what? They all lead to involvement of the median nerve. You know that very well. That is what you call carpal tunnel syndrome, right? That's what you call carpal tunnel syndrome. Okay, number 2 entity is in the wrist area. It's in the wrist area. It is called as what? Guyon's canal. It is called as what? Guyon's canal. And what is the nerve involved here? You all know that it is in the hand under the pisohamate ligament. That is the ulnar nerve, right? Number 3, entity called as the chiralgia paresthetica. Entity called as what? The chiralgia paresthetica, right? The chiralgia paresthetica. What is that chiralgia paresthetica? What is that chiralgia paresthetica? Chiralgia paresthetica is compression of the superficial branch of the radial nerve, right? Superficial branch of the radial nerve. When you go little up in the forearm area, the entity is called as the pronator syndrome. Entity is called the pronator syndrome. What is that compressive effect of? Pronator syndrome is basically a compression of the median nerve. It is a compression of again the median nerve under this pronator teres. Number 5 is an entity which you call as cubital tunnel syndrome, which you call as the cubital tunnel syndrome. Cubital tunnel syndrome. What is this nerve involved? The nerve involved is ulnar nerve, which has been the question of the 23 mid-year exam. Okay, cubital tunnel syndrome. Then when you go little up, fracture lateral condyle we have marked already, but I'm writing it here to complete the table. Lateral condylar humerus, guys, again it is the tardy ulnar nerve, again ulnar nerve. And here is a very, very important injury just below the lateral condyle. It is a fracture Montegia, right? Remember, it is a fracture Montegia, which involves which nerve? It involves most often the posterior interosseous nerve, which you know very well is a branch of which nerve? It is a branch of the radial nerve, right? Number 8, the fracture Montegia. Then we have the fracture supracondylar. So I want to highlight here, guys, in the exam, in that tense environment, no, something may sometime be lacking, in the mind. So these are 2 most commonest injuries which might be giving you some confusions in the exam. Fracture of the lateral side and nerve of the medial side, and fracture of the medial side, that is the ulna Montegia, and nerve of the lateral side, right? So this is how we may sometimes get confused. So there is a cross, all the time, cross mismatch kind of attitudes here. So you should always remember that the site might be confusing sometime. Okay, so supracondylar, fracture supracondylar, it will involve most commonly what? AMRU, like you just said, AMRU. Yes, absolutely, you are right. Okay, 9, The fracture shaft of humerus. Fracture shaft of humerus most commonly involves which nerve? We know very well that it is a radial nerve, right? But yes, in the question that we have just seen in the exam, it was musculocutaneous nerve. So nerve can be any which is involved. We are talking about the most commonest, okay? Whenever the radial nerve is involved here, there has to be a wrist drop. And then when there is a fracture of the shaft of humerus and then fracture neck of the humerus, or there is a dislocation of the shoulder, fracture neck of the humerus or dislocation of the shoulder, then which nerve is there? The most commonly involved nerve is axillary nerve. You know it very well, it is an axillary nerve. And then number 11, the axillary nerve. Then number 11, we have the thoracic outlet, we have discussed already. So that was a vasculogenic part we discussed. And thoracic outlet can also have a compression of the lower trunk of the brachial plexus, right? Lower trunk of brachial plexus. Now number 12 is under the inguinal ligament. What is that entity called as? What is that entity called as? Meralgia paresthetica, right? The entity is called as meralgia paresthetica, and that is lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh, okay? Lateral cutaneous nerve of the thigh, right? So now, okay, all right. Okay, so lateral cutaneous nerve of thigh. Number 13, after that meralgia, we have discussed about the posterior dislocation, or basically the meralgia paresthetica, this posterior dislocation or the injury, right? That is a sciatic nerve, right? In the neck of fibula, the nerve to be involved is the common peroneal nerve, which leads to foot drop. We have discussed that point. Number 14 is what you call as the tarsal tunnel syndrome. What is a tarsal tunnel syndrome? When there is a posterior part of the tibial nerve getting involved, the posterior tibial nerves getting involved. And number 15 is a entity called as Morton's metatarsalgia. What is that entity? It is a compression of digital nerves under toes. Okay, it is a compression of digital nerves under toes. So at what all fractures, what are the injuries which are common, which nerves can be involved, like that is another table we have. Okay, so these are usual, confusing, the two most common to be confusing us all the time, right? So this is your table number 4 we have made. That is a table number 4 we have made. Okay, I hope it is fine. With everyone. Shall we go with the next one? So answer number 7, I'm going back to that again. So question number 6 has to be D, as the reason we discussed earlier, right? Toe tenderness. Okay, number 7, it is a fracture shaft of humerus, agreed, but the presentation of the patient is little different. Similar way, in the coming questions, we are going to make up multiple tables where we discuss about how the shoulder is coming up to you with abduction, why the hip joint is coming to you with abduction, why the hip cannot have adduction, the differentials. Okay, and in one simple table we'll try to discuss multiple MCQs of this test paper, right? So musculocutaneous should be very clear to everyone. Then this one, number 8, you answered it very correctly. Yeah, all right. So this is PDF will not be possible. As I said, you have to note down as I'm writing down. I am also writing, and you also have to write with me only. Okay, so it will not be possible to send any kind of PDF or annotated note. You have to make it yourself, right? So I'm discussing it so that we all can recall, we all can remain energetic all the time. So this is about your question number 8. Let's move on to the question number 9. So my team has just messaged me that we need to change the link. The YouTube relays, I think, will be stopped now, probably. That is what they have told me. Okay, and now just hold on for a few minutes maximum. I think it should be like kind of 5 minutes. So it's already like 5:30. We are not taking a break. It's not a break. I'm here itself. It is 5:30 and we are coming back at 5:35. We are just changing the link only. Okay, we are just changing the link only.